All right, welcome to the episode of the Cod and Cocoa Report. I'm super happy to have a number of different people on. It's a little bit unusual compared to our usual reports. We have Tom Wingert, who's a patient who's going to describe his experience with a sub-Q ICD that he had placed some years ago. How he got to the point of getting the sub-Q ICD placed, and then some of the issues that have developed since that have been placed. We have Dr. Bogdan Anake, who's a Romanian cardiologist who works in Monaco right now. I'm envious. He was telling me that he bikes from France to Monaco. He lives in France, works in Monaco, so that'll get many of us envious. Dr. Jha, whose commute is much less interesting, who many of you know. Dr. Jha is an academic radiologist of much disrepute at an institution of much repute, who is giving us his time to talk a little bit about this case as well. So welcome to all of you. Thank you so much for coming on.
Thanks for having us.
So Tom, we'll start right away. Tell me how this all started so many years ago. What was the initial problem that you had?
Sure. So a few years ago, I guess we're coming up to, it's either 2 or 3. It's hard to remember at times, but a few years ago, I ended a work day, and it just was, normal-ish work day. I guess particularly busy time. I'm working marketing, and oftentimes I'm just like pulled in a lot of different directions. It was one of those days, but nothing out of the ordinary there. I get home, I do what I normally do, and just kind of sit down, read for a bit, just kind of unwind for the day. I got up at a certain point from just sitting down and decompressing, and walked across my apartment at the time to use the restroom, and kind of flip on the switch of the restroom, and then wake up several minutes later, having fallen across the restroom and fallen into my bathtub and kind of passed out. I had no experience doing anything like that, never had blacked out or passed out in my life, and kind of freaked me out. So, I spoke to my then girlfriend and now wife, and she was just like, well, you should, go see a doctor about this. And I said, okay. I had no real medical conditions, so it's not like I was in regular communication with any specialists or general physicians or anything like that. So I went to an urgent care the following day. They said, hey, people pass out all the time. It could have been any number of things, but you're in your 30s now, might as well have you checked out by a cardiologist and a neurologist. So I was able to get an appointment with a cardiologist a couple of days later. They ran an echo test, and just kind of sent me on my way. After the results of the echo came in, there was then an MRI that was ordered, and I'm going through the motions at this point. I don't necessarily know what's being seen, or even if it's being explained to me, I don't understand it. I work in advertising, not medicine. Right. And after the MRI, there's a period of about 10 days ish where I don't get any news, and then I have a emergency appointment set up with electrophysiologist, I think is the descriptor. And
I'll stop you there.
Go ahead.
To fill in some people in terms of the details of how why this was happening in the background. This is great, because that's what that's what's being surfaced to you, if you will, right? And so what happened is Tom went and got an echocardiogram. We went to urgent care, and the urgent care folks said, hey, this is something that very commonly happens in people where after an episode where they're urinating, they pass out. There's even there's a name for it. It's called a phrase for it, micturition syncope, which is, again, it's something that has happened to, may have happened to some of the other colleagues on this Zoom at some point or the other. So the urgent care was not that concerned, but any young person that's passed out, they in general say, hey, go see someone. The EKG that you had done, the electrocardiogram that you had done looked okay. So you had an echocardiogram done, which is an ultrasound of the heart, and that ultrasound with a cardiologist, that ultrasound of the heart showed that the right side of your heart was a little enlarged. Now, to fill in a little bit of details, you've told us that you've had no medical history, partly because you don't see physicians, but that's also because you're extremely fit, correct? You're an endurance athlete, correct? You run a fair. So tell me, how much do you run, and
Yeah.
what do you do?
I'd actually say I'm an endurance athlete now. Prior to that, I played basketball, I played football, high school, college, and then at the time of this diagnosis, I was the vice president of marketing for a fitness company in Philadelphia, where, yes, there's business duties associated with that, but part of it is also, being really fit and working out all the time. I was the spokesperson of this company, and I would like be on the news with my shirt off and things like that. So I would do, box jumps, deadlifts, kettlebells, stuff. Like I was in very, very good shape for a very long time.
Okay. So you're a very, very active guy. You are not like, at least I can speak for two of the folks on here, a sedentary couch potato. So you went to, so one of the interesting things that you may have forgotten about now is that you had a Holter monitor placed. You
Oh
remember a
God.
little monitor placed, and this is kind of an amusing scenario. Well, not amusing at the time, but in retrospect, it is, where you had this Holter monitor placed because they were monitoring you for some type of arrhythmia, and at some point, I see all these notes in reviewing your chart, that the monitor went off, and one of the monitoring company contacted the on-call physician to say, "Hey, the monitor has gone off, and it says something about fainting. We have tried to contact him. We're unable to contact him." And of course, this all happens at like 10 p.m. at night. It's a fellow that's on call in the hospital, and the fellow tries to call you. And again, there's all this history in the background, right? There's a young man who's syncopized. That was the initial complaint. Now he had an ultrasound done. His right heart is big. Now the monitoring company has called me and said that we cannot get in touch with him, and someone hit an alarm. And so he tried to call. He was unable to get in touch. And so eventually, after 3 or 4 times, the young fellow actually called emergency medical services and sent a ambulance to your house, and nobody was there. And then finally, the next morning, you got in touch with them and said, "Hey, everything's okay," and I think I hit the button by accident.
So what had like ultimately happened, that's basically correct. When I was initially setting up the Holter monitor, what I didn't know was that if you open the box, it is on. At least at the time. I don't know if that's true now, but I don't have to dial a number. I don't have to set it up. As soon as you take that thing out of the package, it's ready to go. So I put it on, and this is, again, with my then girlfriend, we're both sitting there, and I was just like horribly embarrassed because this had all happened so quickly, and I'm thinking like I have to carry around this Walkman all the time and have this thing when I'm showering at the gym or like whatever. It really freaked me out, and it started beeping immediately. I have no idea why, because I didn't calibrate it or something. And it was late at night, and I just said, you know what, I'm going to go to bed. And I was at her house. I woke up the next morning to, like you described, about 30 missed calls, including a message from my neighbor who had said, like, "Hey, I have Meatball. Meatball's my dog. I have Meatball in my apartment. Like, let me know if you're okay." So I was like, "What is happening here?" I call her. She says not only was there an ambulance, but there were police and the fire department who had kicked down my door, and gotten my dog. My neighbor got the dog or whatever. But I returned home to my apartment the next morning with my door smashed in and all this stuff missing, and I was like, "This is nonsense."
At this point,
I was perfectly fine.
At this point, Tom is ruining the fact that he ever went to see a doctor.
Yep,
so
pretty much.
So the story gets even more interesting because the cardiac MRI. So I bring that up just because, and reading the chart and going through your history, it's clear there's this amped up level of concern, and these, and this is kind of, I think, part of it. Everyone is on like hyper alert setting because of what's been found. So now you go and get a cardiac MRI done, and as you said, a few days after, or 3-4 days after the cardiac MRI was done, suddenly you're having an emergent appointment with an electrophysiologist. So this is where Dr. Jha comes in. So Saurabh doesn't remember this. When you came to see me 3 years ago, I actually showed him your pictures as well. But to refresh him and not to prejudice him or bias him, I showed him the images again a few days ago, and said, "Saurabh, what do you think?" One of the concerns with, and we'll get into that just in a minute, but one of the concerns when somebody presents the way you do, with abrupt syncope, usually with no other identifiable cause, with some structural abnormality in the heart, specifically here the right side of your heart being big, one brings up the kind of the bogeyman for cardiologists, and is what's called ARVD, arrhythmogenic right ventricular dysplasia or cardiomyopathy. And that's always a concern, and we suddenly have to try to figure out whether or not this is something that may have caused that passing out event or not. And it's important because, of course, if you have that, then you may have another event, and this other event may be fatal. One of the ways of making that diagnosis is now kind of the de facto way has become using cardiac MRI to make the diagnosis. I'm using those words carefully because I said using the MRI, not having the MRI make the diagnosis. So I showed you the pictures of his cardiac MRI. What are your thoughts on what you saw?
Yes, I did not have Tom's detailed description at the time, so he was just like anybody else. But it did strike me that his right ventricle and right atrium were large, certainly larger than mine would be, for reasons that you have already stated, because I'm a couch potato and he's not. So he comes under the description of athlete's heart, which, as you cardiologists know better than I do, when an athlete does a lot of work, their heart pumps more blood, not by pumping harder, but by increasing the volume because of these Starling's forces, laws. So his right ventricle was large, much larger than you would normally encounter, and the right atrium was also large. The trouble is that the disease that most cardiologists fear, ARVD, also leads to a large right ventricle, and mostly right ventricle. And so there's an overlap between the two things, and they're obviously dramatically different. An athlete's heart is a good thing. That means that the person is cardiovascularly fit and has reduced complications of other cardiovascular diseases. But the other entity, as you know, is potentially fatal, and nobody wants to miss that. So this type of presentation I get a lot. I read a lot of cardiac MRIs, and I get this very typical presentation history of a young man with athletic activity who has a fainting episode, and you don't know the fainting episode is from overactive vagal nerve or because there was an episode of tachycardia that led to reduced blood volume. And so what happened when cardiac MRI was used to find the diagnosis of ARVD was that we had criteria, major and minor criteria. And we found that the initial set of criteria that were used we were still missing stuff. So the criteria got finer. And the criteria basically is that you have to have a big RV with what's called segmental wall motion abnormality, which means part of the RV isn't working. Not the whole of the RV, but part of the RV isn't working. And also the fact is that the RV has to be disproportionate to the LV. So if the LV isn't working and then the RV isn't working, then that's a different disease process altogether. But it's when it's the RV that's particularly not working. So you have somebody who has an athlete's heart that looks like the RV isn't working because it's not contracting as hard, because it doesn't need to, because it's got all this volume. It looks like it's dilated, but you get the causality referred. Now you start looking at the segments, and whoever reads these scans, you're reading it in a kind of a clinical vacuum. You don't know the index of suspicion. There's this looming threat of sudden cardiac death that you imagine from all the press coverage and everything else that has taken this issue. And so, though I do not see any segmental wall motion abnormality in this particular case, I think that it's such a gray zone that if you start staring at it, you can immediately overcall it.
Right. So, I mean, so you can imagine, that it's if a cardiologist comes to you saying, "Hey, I'm really concerned about this gentleman. He has, my concern for this is high, right? My clinical concern for something bad is high." And he says, "So tell me what you think about that RV." That may lead to a very different result than, if you just are reading it in a vacuum. Is that a concern of yours in terms of when you're reading, how much the clinical context affects what you try to read? Because, as you said, this is very gray and it's not black or white, correct?
Yeah, it depends on how obvious the findings are. Sometimes they're so obvious that
Right.
it really doesn't matter what the degree of concern
Right.
is, and sometimes they're so clearly normal that it doesn't really matter. And the best you can say is, "Hey, listen, there's nothing here," but that doesn't mean that there can't be anything. There's
Right.
nothing here.
But Tom's
It's
case, but
In,
Tom,
in in Tom's case, if you have a young man with athletic activity without history, and you can end up overcalling, particularly if there is that
right.
amber alert that you were talking about.
Right. But in Tom's case, the findings are not blindingly obvious for ARVDC. He's an athlete. The large heart can be explained, but so it could be normal, but you can hedge by saying that this it also could not be, which doesn't help you a tremendous amount. So the way the study was read, the cardiac MRI was read, was a dilated and akinetic right ventricular apex with increased indexed volumes, right ventricular volumes. This meets the threshold of arrhythmogenic right ventricular dysplasia. Is that how you read these studies that are in the gray, or any?
Yeah, that's the problem when you have all of these criteria that are given, like the major criteria and minor criteria. It almost seems as if there is this threshold that you either meet or you don't meet. It almost seems like an aspiration.
Right.
And I think that's one of the problems with this sort of, decision, this sort of rule-based approach, is that it doesn't allow you to think of the patient as a whole. Now they're going to say, well, nothing's stopping you from doing that, but you've got, you've got these kind of check boxes, and you're thinking, do I meet it or do I not?
Right.
You're not thinking globally about the whole thing. You're thinking
right.
like, a piecemeal, and I think that is the way it is read. I think that helps in some issues, some cases, but it also hurts in other cases.
But it creates a, when you read, I mean, do you think it's okay to make a diagnosis of ARVDC based on a cardiac MRI alone?
It depends on the spectrum, but mostly I would say no. I would think that if you are to read the cardiac MRI, it has to be done with a fairly accurate representation of the pretest probability, which in many cases would mean a documented ventricular tachycardia that originates from the right ventricle in morphology, and not simply a history of syncope, which can be from myriad of causes.
Right. Tom got consultation from a senior EP physician kind of right away. U.S. healthcare system works very fast when it needs to or wants to, and the comment was that this is a patient with a history of abrupt syncope, has an abnormal cardiac MRI study consistent with the diagnosis of ARVD. The clinical finding of syncope places them at high risk for sudden cardiac death. For this reason, I recommend implantation of an ICD. I am recommending a subcutaneous ICD because of his young age and the fact that he has no indication of cardiac pacing. I told him I'm comfortable with the diagnosis of ARVD, even if he does not have a positive genetic test. I also see no reason for other testing, such as ambulatory monitoring or EP studies, since he already is at high risk, given the finding of syncope and a positive cardiac MR study. So that, I mean, is really weighting that abnormal cardiac MR study. So it sounds like basically the electrophysiologist is saying, I cannot ignore what the cardiac MR findings are, and this is what we're going to move ahead with the sub-Q ICD. Tom, how is oh, actually, Bogdan, let me get you in. Bogdan tell me, what are your thoughts? What are your thoughts in terms of the diagnosis here? Is this, we're of course biased because we're in the States. Is this how things are done across the pond in Europe as well?
So thanks for having me on, and it's a pleasure to be here. So I was thinking about this case because, I mean, I see, all my colleagues see a lot of patients with syncope. Some of them are young, and we've all learned these things, that the three most important things about the syncope evaluation is history, history, history. And then comes everything else: ECG, MRI, ultrasound of the heart. I think of course, the context, could it be vagal, is a very, very important aspect. And then, of course, so it sounds very familiar to me, the thing where you ask for a cardiac MRI, and then the results are a bit hedged on well, it could be, yeah, maybe. And then, of course, nobody wants to hear that a young patient they saw 2 months ago or something like that died of a heart attack. So those are not equal outcomes if you put in a device, or if you follow up later, or just leave them be. Perhaps the only thing I've thought of during everyone else explaining is that perhaps, but this is of course hindsight, perhaps we would have suggested to the patient, to Tom in this case, an implantable loop recorder if he's not comfortable with an SICD, which would be, of course, the remote monitoring. He would send us data every day or every time he would have alerts. And at the slightest, as Saurabh mentioned earlier, in this case, there was no VT recorded. So a VT recorded, even unsustained, asymptomatic, would reassure us in proceeding further with an SICD or an ICD.
No, it's a nice summary, Bogdan, that, and again, that's the thing that keeps cardiologists really up at night, is that, my goodness, if you don't do something and suddenly a young man is gone, and you bear the responsibility for it. It's almost easier for the health system to then intervene and say, all right, best case scenario, let's just intervene, take care of this, and, I can sleep better at night. So, and this is a great segue. So Tom, what we're talking about is, what Bogdan was just mentioning was that, some type of monitoring to look to see if you had any VT, any of this arrhythmia that's bad that can result in sudden death. And of course, you had a monitor done. The monitor didn't show anything. The only thing it resulted in was a misfire, which caused your door to be kicked down. But tell me about how that conversation went in terms of, they were saying, hey, this, yeah, tell me, describe, I won't put words in your mouth. Tell me how that conversation with the electrophysiologist went. How did he summarize things, and what did he recommend?
Yeah, so, and this is the first time, obviously, I've heard the like medical language behind the diagnosis, and it's pretty declarative and firm, which I think reinforces what my experience was as the patient. But yeah, this is Valentine's Day of whatever year this was, either 2017 or 2018. And I go in for the MRI results to meet with the EP, and he basically sits me down and he, says, okay, you have something called ARVC. This is what it is. This is what can happen. You need to stop exercise immediately, and we need to implant an ICD. He kind of explains what it is. Didn't particularly accurately describe the size of the device. I found that out on the table. like an external hard drive, which was a little surprising to me. But yeah, I mean, that was basically it. And I in kind of speaking with them, there's a couple of things that come up for me. One is, how did this happen as quickly as it did? Because I had gone from no history to, you now have like about 3 weeks later, I think at that point, you now have to stop exercise and get a life-saving device implanted into your body. You now have a heart condition that is, something that can kill you. But then also like the logistics around it. It's like my job is literally, I am the vice president of marketing of a fitness company. I do this on the news. Can't do it anymore. Like it just all was so fast, and I was just so freaked out by the whole thing that I just said, yeah, let's go, I guess, and I'll just figure out the rest later. And that was how that went down.
Yeah, I know. Was there any conversation about the type of life-saving device you would have placed? So now we get to this.
Yeah. So there, the way that it was described to me is there's this option, the ICD, new technology, you barely even notice it, which a couple years later is true, when I don't get an inappropriate shock, but I don't notice it anymore. Or a pacemaker, which he said is basically a bit more invasive, and it serves other functions beyond just resuscitating you or starting up the heartbeat. So I went with that, but that was basically the two options that I had. You need a lifesaver. You can either get the subcutaneous or you can get a pacemaker.
So were they put forth to you as basically equivalent devices? Were there any downsides of you ultimately ended up having a subcutaneous ICD placed, which is a defibrillator with a lead that's not intravascular. It doesn't go in the heart. It basically courses around your thoracic cage subcutaneously. And that's what you ended up having done. Were there any downside talked about of having that device?
No, I mean, both were essentially all upside, with the pacemaker having the downside of, we don't know that your condition is one that would need the regulation of a heartbeat, and it is a more invasive device by its nature and a procedure to get it in there. So the ICD that I ended up with was one that was presented with basically only upside. It'll save your life, and it's basically going to be something that doesn't, after you get the thing implanted, you don't notice it.
So Bogdan, the device is the subQ-ICD is being presented as basically substantially equivalent to the transvenous ICD, and this is where you come in. Bogdan has been instrumental he's been following this. The data on the subcutaneous ICD since the original trial came out. Him and John Mandrola wrote one of the original letters to the editor based on the original trial that was done, that was published in the journal. So, Bogdan, what do you think? Is this an equivalent? Is this how we should be presenting this to patients, as substantially equivalent?
So I don't think we should just call them equivalent. I think there's a discussion to be had about the advantages and the disadvantages of each device. And I'm not saying, and we never said that there are no advantages to the SICD. We've all seen cases of infections of the classical transvenous device, the one with the leads in the heart, where an infection of the skin around the device can get the bacteria inside the heart. You can have an endocarditis, and that can be a lethal situation. So it's not without disadvantages.
Right. And to be clear, Tom is very young. He has 50, 60 years of life ahead. The thought about a indwelling lead in a vein in the heart is obviously, that is not without risk. He's going to have multiple generator changes each time that puts the whole system at risk for infection. So the traditional transvenous ICD clearly has significant downsides, especially for a young person, no question. Which is why the subcutaneous ICDs were so attractive because the lead isn't intravascular. But go ahead. Sorry.
Yeah, no, you're absolutely right. And then where we come in, and so in last summer in the New England Journal of Medicine, there was a randomized control trial with a non-inferiority design, which we could eventually get into the details of what it means. Basically, that the SICD is not much worse than classical ICD. And John Androla and Rita Redberg and I wrote a letter to the editor because we had some points of contention with the trial as it was published. So the SICDs has been used for years now, especially in younger people with like Tom's case. They were healthy before, they didn't know they had any history, and then they find out they have this weird cardiac condition which could leave them with a deadly arrhythmia. What the Praetorian trial, the trial, so last year's New England Journal paper, took a more general population, so almost any patient with an indication for an ICD, with no need for pacing. So exactly what Tom said, that these hearts don't need any pacing. And they looked at the rate of complications, so such as infections, and what they called inappropriate shocks. And this was our main point of contention, that what they called inappropriate.
So the study so the main issue that was recognized, even prior, was that because the downside of the sub-Q ICD device is that because the lead is not inside the heart, there are things that it cannot do, and one of the things it doesn't do as well is it has a harder time differentiating abnormal from normal rhythms. If that is a problem, because basically you have a shock box that's sitting in your heart that's monitoring your heart every second to look to see if you have an abnormal rhythm, right? So therefore, you need to make what you need to have is something that is very good at discriminating normal from abnormal, right? If your new technology that has much less complications from an infection standpoint is not as good as discriminating between normal and abnormal, that means that increases the chances you're going to have a lot more inappropriate shocks. The trial designers knew this, so therefore it was built in, it was baked in, right? The endpoints were that was one of the endpoints, was inappropriate shocks.
And this was one of our objections to it, that this endpoint of inappropriate shock, of course, you have to have a definition for it, usually before the trial starts. So in this case, the definition of it's a bit technical, but the definition of an inappropriate shock for them was actually anything that is not an appropriate shock. So then you would have to go see the definition of an appropriate shock. So when the trial began, I think it was 2010 around, their initial definition of an appropriate shock was ventricular tachycardia, so the bad rhythm, which beats faster than 180 beats per minute. And at a certain point in the trial, which was not obvious, which was not published, they changed the definition from an appropriate shock is a ventricular tachycardia of more than 180 beats per minute to an appropriate shock is for ventricular tachycardia, or VF. And actually this led to the inclusion as appropriate shocks of what we call slow ventricular tachycardia. So a special kind of ventricular tachycardia that beats around 130, 140, say, beats per minute, which is not usually an immediate danger. That's why the devices are not programmed to give shocks. But the ICD in their trial identified this as an appropriate shock. They called it appropriate, right? Appropriate, and it shocked the patient.
They changed the definition. They changed the definition of what was defined as appropriate or inappropriate shock. And for most for most cardiologists, if you have a slow ventricular tachycardia, right? Ventricular tachycardia is an abnormal rhythm. It is normally, you don't shock it usually unless it's causing a problem to the patient, right? If the patient is in front of you, and they don't have a defibrillator, and you're watching the rhythm and the heart rate, and they're in ventricular tachycardia at a heart rate of 120, we typically don't shock the patient. We do something else. That's the same thing. That's the same way the transvenous, the old device, not old, the other, the established devices, they do the same thing. They do not want to shock unless you go above certain. Because why? Because shocks are highly distressing to patients. Shocks over time can cause increased mortality, blah, blah, blah. So there's many, many reasons why you don't want to shock patients whose rhythms are too slow. And inexplicably, I think, they changed the definition so that even folks that had slow ventricular tachycardia that were shocked by the device that Tom has, the sub-Q IC Tom has, they defined them as, no, those were appropriate. And it gets a little worse, I think, Bogdan, in that the reason these folks were shocked, because Tom's device is set up so that if the heart rate goes above, only if it goes above a certain rate, will it even try to shock, right? Tom's device is not set up for a heart rate of 110. It doesn't matter what rhythm it is, whether it be a narrow complex or a wide complex or ventricular tachycardia or not. It doesn't matter. Tom's device is not set up to shock him. So the only reason Tom's device would shock him for a ventricular tachycardia at a slow rate is because the device is miscounting the VT. It's oversensing the VT. It's sensing T waves in addition to the QRS. So his heart rate of 120, the device actually thinks, oh my God, it's 240 and I need to save Tom's life. So it's a little mind-boggling that in the NEJM, in the little table, in the New England Journal of Medicine, in the little table, it says, under appropriate shocks, it has 11 slow VT events. And that's significant because if you adjudicated those to be inappropriate, the trial would probably not have met its endpoint. And if the trial didn't meet its endpoint, would it have been approved? So the top line results from the NGM, and I think the message that's gone out to most cardiologists is these are equivalent devices, that they're non-inferiority means equivalent. No. Actually, the trial designers knew that you were going to have more inappropriate shocks, and they said it's okay if you have a few more inappropriate shocks if we save this, if we have more benefit on this end. That's just the general trial design of non-inferiority trials, which is understandable and okay and fine. But in this particular case, there were way more inappropriate shocks than what's even outlined, and so it would not have met your non-inferior outcome. Is that a fair summary there, Bogdan?
I do. I just want to stress out as well the fact that you have a device which is programmed to identify rhythms over 180 beats per minute, so standard programming, and it detects something which we all agree is, let's say, 120 or 130 beats per minute. To call this appropriate and to not call it a misinterpretation or malfunction or whatever you call it, of the device, to call it proper working, is just mind-boggling to me.
Right. So Tom, back to Tom. Tom, you had the device put in. The device was larger than you thought it was. How did the procedure went? How did things go? The procedure went pretty well.
Yeah, it was fine. Surgeries are always, you wake up afterwards, you're like, that hurt more than I thought it would, but no big deal. I've now got a thing, you recover, whatever. So you were told, partly because ARVDC is thought to be exercise may make you decompensate further, may make the right ventricle get worse over time. You were told to limit and curtail your exercise, and you kind of, we'll move quickly over this part. You did modify for a period of time. You were running, and then what was the next time that you were forced to meet the folks in the ER again? Yeah, so basically when I got the diagnosis and when the recommendation for the implant went in, EP basically said, there are also plenty of athletes that have this thing. There are NHL players, there are whatever else. The guy from Boston Scientific kind of reinforced that. So I was like, okay, like I understand the guidance is like, take it easy, but you've got some wiggle room. So I took it pretty easy for quite some time, some basic strength stuff, a lot of yoga. And then my wife, who is herself a pretty serious endurance athlete, she wanted to do like a kind of goofy like obstacle race. And I agreed to do it. And I just said, hey, I'll just watch my heart rate the whole way through. It's an obstacle race, like you jump over stuff, monkey bars, that kind of thing. I'll watch my heart rate all the way through, and it'll be fine. It's no big deal. And it was no big deal. Like my heart rate never really went above, I think, like 140, maybe. But then somewhere in the middle of the race, I climb over some monkey bars, land from climbing over the monkey bars, turn around to watch my wife, and what I found out after a minute or so was an inappropriate shock hit me. I thought somebody like threw a boulder at me or something. Floored me, hit the ground. I hear somebody say in the background, "Oh man, he just went out," because it's a public setting, whatever. And then I realized, like, oh yeah, I have this thing that I got put in me that does this sort of thing, and I guess that's what that feels like. But yeah, so we drive back to Philly, and I go back to the emergency room that I got the implant in, and they told me, yeah, that's what the thing does.
So
it was also a Saturday, so we couldn't get a cardiologist on the phone. So I was there, all day. It was just, whole thing.
So is that the first time you'd heard of inappropriate shocks?
Oh yeah.
Yeah. Bogdan, you would say that we probably want to be telling our patients about this as a downside, yes?
Absolutely, and absolutely. I mean, I don't think there's further comment. Because this is something we're used to explaining. We're used to explaining inappropriate shocks with the older type, or the classical type of ICDs. Is just something we discuss about.
So how has this impacted your life moving forward?
Yeah, I mean, you and I have done some work on this, and we've played around with the device and programmed and tried to figure out appropriate limits to the point where I don't understand the programming, but essentially the programming knows to account for certain tendencies with my bloopies, so to speak. But it does. It's always something in my mind that it could just go off at any moment, because while I popped right back up and I was basically okay, it's extremely unpleasant. And then you think about, well, what happens if this goes off while I'm driving, or while I'm traveling, or like I have to travel for work. It's just, I don't like having it in me. I have, since the pandemic, since the shutdowns, I started running. I was not a distance runner or an endurance athlete before that, and I needed to get outside. I needed to do something. There was no way that I was going to be in my apartment for however long I was going to have to be in my apartment. And I pretty closely watch my heart rate while I'm doing that, which means sometimes I can't go as fast as I might like to, or push myself as hard as I can. Which is fine. Like, that's a complete luxury problem, and I assume no ill intent or whatever else. But the basic answer to your question is, like, I'm always worried about whether or not this thing is going to go off for no reason. I have a nagging question of is this even in here for any good reason in the first place? And it's an inconvenience that kind of freaks me out quite a bit.
So, yeah, Bogdan, you wrote in a Jack editorial suggesting that, so the story gets slightly more interesting, right? I forget exactly when. If it was 6 months ago or so, maybe getting the timing wrong, where Boston Scientific reported and issued a recall or whatever, an alert, some type of alert message, because the lead that courses subcutaneously around the thoracic cage there's a weak point that is more susceptible to fracture. So beyond the difficulties with sensing and oversensing and tachycardia or whatnot, that can cause inappropriate shocks, now you introduce the fact that there's a failure rate of the lead that when it makes that bend around the chest, it can fail there, and if it fails there, then it can actually create problems. There have been some injuries reported, though very, very rare. So you actually, Bogdan, with I think John,
Yes.
called based on that and based on your earlier concerns in terms of adjudication of these shocks and whether or not the original trial would have met its endpoint. You actually called for cardiologists to pause placing these devices in. Is that something you still feel?
Yes, absolutely. So after our letter to the editor, after all the debates around the New England Journal paper, I think it was around December or January. So it started with a recall from Boston Scientific, the manufacturers, but it got picked up, or I don't know the proper term, by the FDA. So finally, it ended with a Class 1 FDA recall, Class 1 recall, which the FDA calls the most serious type of recall. Use of these devices may cause serious injuries or death. They recalled the lead, and they also launched a Class 1 recall of what is now a previous generation of the device itself, of the can. So the types of can which were used, I think, between 2017 2019, and the leads which are currently the leads which are currently used. So bearing in mind the doubts around the New England Journal paper, the FDA Class 1 recall of the only lead on the market, because that's the only lead you can use. Yes, we called for, let's say, a suspension of procedures by our colleagues, and I mean by us as well, because we implanted them as well, until this is, let's say, clearly looked at. And from what I gather, so at least in Europe, I'm thinking the US should be the same. So Boston Scientific is launching a new type of lead, where the weak point was corrected, and I think it should come around in September or October. But for me, all this period where there's so much uncertainty, so many doubts, it's not like we don't have any alternatives at all. So I think it's common sense, let's say, to at least consider the suspension of its use.
Thanks, Bogdan. So at this point, because of this lead issue, and there is no other lead available, as you're saying, why even implant? You already have higher inappropriate shocks. Why even implant this device in the system? And I'm not sure if that. I don't know if anyone is really acting on that. It's interesting. Once things get approved, devices gets approved, it seems rare, unless something really serious happens at a large rate, for anyone to actually recommend stopping it. The point that the folks from Boston Scientific make is that, hey, okay, fine, you're going to take this device out of the equation, then these are still folks that need the device. What are they going to get? They're going to get a transvenous lead with the long-term complications of that. And oh, by the way, it's not like we've never had a transvenous lead recalled as well, right? I mean, it seems like every 2 years we have a transvenous lead that has some problem that is causing things that is creating a recall. But yeah, I think, Tom, thanks so much for kind of clarifying all that. It's really great, and thanks for being so up on it. I think one of my issues, as putting on my my libertarian leaning hat when it comes to some of this FDA, the regulations and stuff, is that one of the things it seems to do, like when the FDA says this device is approved, like I feel like a ton of cardiologists, and partly because we don't have time. I mean, there's so much data and information constantly coming out. Like, who's actually going and reading the actual trial and seeing beyond the top line conclusion? The top line conclusion, the New England Journal of Medicine and the FDA, is this device is substantially equivalent to an ICD, right? To a transvenous ICD, and that's what's presented to Tom. And I don't know if we as we in the cardiology community are necessarily doing the best job for patients like Tom if we are simply just taking the top line analysis from the FDA, from the New England Journal of Medicine, without kind of doing our own critical analysis. So
yeah, I think the way to answer that question is to randomize cardiologists to those who blindly obey the FDA and to those who actually read the data. Sorry for that cheeky interlude, but I wanted to poke fun at Bogdan. It is obviously this is kind of like a Greek tragedy with Tom's symptoms starting off and going to the physician and getting amplified at every opportunity by the medical system because of this baseline level of fear. And I don't know what the solution is. And I think maybe the solution in this particular situation would have been to more testing, not less testing, more testing. Because one thing we tend to do in this gray zone situation is ask for the MRI to be repeated in 6 months. And if it's a process that is a primary disease, then things get worse. If it's not, then things stay the same.
you'll make it a lot easier for us, sir, if your colleagues don't write this is diagnostic of ARVDC. I think a lot of cardiologists are going to be very nervous. Me too. That if you come with this diagnosis by a radiologist in a young person, it's like, all right, so we are going to wait. So I think, Bogdan's point is excellent and well taken, that, place an implantable loop recorder, a sub-Q, tiny little device, Tom, nothing like what you have, tiny little device. I swear, even on the
yeah, I've heard that before.
Heard that before. Right? that goes right underneath your skin, right in that mid-sternal area, and that monitors your heart every second of every minute, and it just sends you alerts. Of course, it doesn't actually treat if something's bad. So worst case scenario, you end up putting this device in, and you end up watching somebody, die because they are in VF, and of course you don't know about it for X number of hours later. But at least the hope would be that you would find some evidence of high risk arrhythmia or something like that. So yeah, but Saurabh makes a great point. If there's some diagnostic uncertainty based on the history, which we shouldn't replace MRIs with. History is still probably more important than MRIs. Repeat MRIs or do additional testing. Guys, this has been fantastic. We're right at an hour. Any additional comments from anyone? Tom, your comments. I know some of the stuff got very technical in bits and pieces here, but your thoughts on kind of going over the case like this?
Yeah, it's really useful to understand the professional dialogue underneath, my human experience. And end of the day, like I know, like I've said it before, that I don't assume any ill intent, ill will, or like malfeasance, or even just like misrepresentation of facts. But I am a young guy, and this is something that, until the battery runs out, I am where I am. And like I do wish, just like hearing this conversation, that there was more certainty and more testing, and hindsight being what it is, this came out of completely nowhere. Right. So next time something like this happens, I'll get the three of you on a podcast.
Sounds good. Thanks, and Bogdan, thank you so much for coming on as well. All right, and thanks for all your efforts and kind of being on top of this. It's really great. So folks like you and John, kind of not just kind of mailing it in, if you will, kind of pushes all of us to really think about these things. So thanks.
That's very kind. Thank you. Thanks for having me.
All right.
Thanks, everyone.
Thanks.